and show some things that typically happen with plantar fasciitis or foot and ankle pain. We can talk more about that as well. And then we'll take some questions and answers at the end. We want to be informative, but we want to be brief. We know this is usually a lunch break for people, and that's what we're trying to harness. Give you a second to catch us on your lunch break, get any questions you might have answered, and get you back to doing what you love, and we get back to doing what we love. So here we are. Co-host. We wait for everybody to join. Again, I'm Dr. Torrance. Dr. Lieber and Dr. Velastro are syncing up right now, and we're waiting on Dr. Pappas. Dr. Lee, we don't know if he'll be able to join us today, but we should have most of our team here today. There he is. Dr. Lieber, you want to give a brief intro on yourself?
Sure, can do that. Just briefly, my name is Dr. James Lieber. I'm a physician here at New Regeneration Orthopedics. I founded the practice a long time ago, and been doing this for many, many years now. And we've gained a lot of experience and knowledge, and the field is really at a tipping point. We're very excited to be able to offer these procedures at the highest level, we believe, throughout the country. So we have Dr. Pappas with us and Dr. Velastro, and I think we probably have a quorum and we can begin.
Absolutely. So, Dr. Pappas, would you like to get us moving?
Sure. So let's talk a little bit about plantar fasciitis. In order to do that, obviously, we need to talk a little bit about what the plantar fascia is. So could we, Dr. T, could you move us along? Perfect. So the plantar fascia is interesting. It's this band of tissue that it kind of, we call it fascia. It kind of looks like a ligament anatomically, but it's actually an extension of the Achilles tendon. So the Achilles tendon comes down on the back portion of the ankle, and then a continuous fibrous band basically starts where the Achilles ends and goes from there under the foot and helps connect the heel bones to the forefoot bones under the foot. And it basically creates this tension that helps support the arch, and ultimately helps the foot provide shock absorption, especially while standing or while walking. Next slide. So plantar fasciitis, then, itis, just means that something is inflamed. So plantar fasciitis is an inflammation of that fibrous tissue, or associated with that can be some degeneration. And sometimes we can have tearing, sometimes small tears, sometimes large tears, and all of these different conditions are kind of a continuous version of each other. And they can all cause pain in similar ways. Typically, at the heel, classically, the patient will say, I first wake up in the morning, I get out of bed, and right when I step down, I have severe heel pain. Other times, they'll say, okay, I've been sitting for a long period of time. I go to stand up. That'll be painful, as well as just sometimes the accumulation of walking or prolonged standing throughout the day will cause pain in that same area. So those are the typical findings associated with plantar fasciitis. We can see this on an ultrasound very well. We can sometimes see tears, or the fascia will look thickened on the ultrasound. We can see this on MRI as well, which can also show tears or thickening of the plantar fascia. It can also show if there's any associated swelling in the bone where the plantar fascia connects to the heel, which might be important. And it can also show us if there sometimes is a bone spur associated with plantar fasciitis that might be contributing to the pain in this area. So, if you've ever had plantar fasciitis and you see the podiatrist or the orthopedist, typically the first line of care you're going to get is something like insoles, physical therapy. Some people will wear braces at night, especially to try to keep the plantar fascia stretched at night. And then, if those things don't work, or maybe right away, sometimes they'll jump right to a steroid injection. And sometimes they'll do surgery where they basically go in, cut around the tendon, and then scrape the tendon to try to debride the tissue there, and then sew you back up. Um, Obviously, there are issues with some of these interventions. I'll let um, Dr. Velastro comment on some issues that can result from steroid injections in particular.
Steroid injections on the surface seem like a great idea sometimes, because typically when you have a steroid injection, it can be a quick reliever of pain as a very potent anti-inflammatory, but there are definite negative side effects to them. And one of those more significant ones is the damage to the soft tissue in the area. So you can, when you inject any tendon or ligament or similar tissue to the plantar fascia, damage to that tissue can then lead to tearing of that tissue, worsening of a tear that's already there, worsened integrity of that tissue. So not only does it not promote healing, but it also worsens the tissue strength. You can also have fat pad atrophy or necrosis. So underneath the heel bone, there is a fat pad which helps with cushion. Every time you plant your foot down on the ground and the heel strikes, there's a fat pad that cushions that impact. Steroid in any area of the body, can cause necrosis of fat, and specifically fat pads. And that is going to decrease the cushion, and then also decrease, or increase, I should say, the pain that occurs when you step down that you're already having with plantar fasciitis. Next slide. Specifically looking at that is this study here, where patients with plantar fasciitis were randomized into two different groups. One of them had that steroid injection, which is kind of the classic way of treatment in lots of clinics. And then the other half of the group had a platelet-rich plasma injection. And the difference between those two, as I already mentioned, the steroid is a potent anti-inflammatory that's injected into the area, but it does not induce healing and actually worsens tissue integrity, while the PRP, platelet-rich plasma, is meant to stimulate healing and repair and improvement of the tissue. So these patients were injected with one of either steroid or PRP and followed over 12 months. They were followed with their pain levels over that time frame and their disability, so their function in the foot. Next slide. So the results, and I think they're better seen on the next slide with the graphs. But as we talked about earlier, with steroid injection, you usually get a quick improvement in pain. And that's what happened in this study. So the initial response when it came to pain in each groups was more significant with a steroid injection. And then following them out, that quick improvement in pain did not continue for 12 months. So the patients in that group plateaued after that initial improvement in pain, while on the other hand, the patients who got PRP had continued healing and remodeling of the tissue, so their pain gradually got better and better, and their function got better and better. So once we were out at the 12-month mark, the patients in the PRP group were at significantly better amounts of pain, significantly better amounts of function, and decreased disability in the foot. And you can see that on the graphs in the next slide. So the red indicates the patients who had the steroid injection. So quick improvement in the pain, but then not sustained quite as much, and then no improvement after that point. Where on the other hand, the blue line is the PRP patients, so they didn't have as rapid of an improvement, but it was steadily improving with time as the tissue healed and remodeled, so that at 12 months, the patients who had PRP were in a much better place than those who had steroid. Other things that we think about when treating plantar fasciitis. So PRP helps the vast majority of patients that we see with plantar fasciitis. But if someone has a very large tear or very advanced plantar fasciitis, sometimes we decide to use bone marrow concentrate. And this can be a more potent treatment of tendon, ligament, fascia, because that has mesenchymal stem cells in it. Other situations we sometimes see are patients who have had a bone spur develop in their plantar fascia. So you can imagine stepping on that plantar fascia insertion along with an extra piece of bone there can really contribute to the pain. So there is a machine called the 10X that we use sometimes that can help debride that bone spur away. And then that helps with the healing in that area and the reduced pain overall. When we see swelling in the bone, so bone marrow edema, we can also do an intraosseous injection, which is injecting into that bone where there is swelling, because those bone marrow lesions can actually be a big contributor to pain. So being able to treat those directly by putting some of the platelets or bone marrow into that lesion makes a real big difference with healing and pain. And then also atrophy of the heel pad. So we talked earlier about how steroid injections can reduce the bulk and the quality of the fat pad underneath the heel. And when we see that, sometimes we will choose to do a graft of fat, which we also take from your body, and put it in that area to help with the cushion there. And that's going to help with protecting that area of the plantar insertion, plantar fascia insertion, and also help with the cushioning.
So that's the presentation. We want to field some questions at this point. Thank you, Dr. Pappas and Dr. Velastro. We want to make sure we get to any questions you might have about plantar fasciitis, any foot and ankle issues, any questions. If you don't follow us on our socials yet, please jump there, give us a like and a follow. We're also on YouTube. If you want to see any of our previous videos, they are all up on our YouTube channel. To give us a like and subscribe there. So does anybody have any questions? Let's see what we got here. Anybody, please put questions. One question I frequently get, and I'd like to pose this question to Dr. Lieber: how do we make sure that this is comfortable? I know injecting the bottom of the foot is very, very painful. So what would you do for that?
Yes, good question, Dr. Torrance. I just wanted to go back for a second. My favorite part of that study was that one of the authors' names is Taco. I've never seen that as a first name before. Anyway, regarding the injection at the bottom of the foot, so it's actually pretty easy to make this a comfortable procedure with the ultrasound and a very small thin needle. We're able to see the tibial nerve, which is right around the inside of the ankle, and then put some local anesthesia around that nerve and create a nerve block so that the bottom of the foot is completely numb. The nerve block itself is virtually painless, and then we can do what we need to do in the bottom of the foot without having any pain associated with that. And then following that, you could stay numb for many hours depending on what kind of medication we use as a local anesthesia. So we discovered that is probably the best way to handle injections in the bottom of the foot.
Awesome, great answer. Thank you so much. What frequently asked questions? We're not getting a lot of crowd participation here. What are some frequently asked questions you get, Dr. Pappas?
Yeah, so a lot of people ask me when I'm considering PRP versus bone marrow derived stem cells. And typically, mild to moderate fasciosis or degeneration of the tendon, I feel like responds very well to PRP. If there's an associated small tear, I feel like that typically does well with PRP as well. But if there's a larger tear or a very advanced level of degeneration. I'll talk to patients about considering bone marrow derived stem cells because I think that is less likely to respond to PRP. You certainly could try PRP first, um, and then if that doesn't respond, always have the bone marrow procedure in your back pocket, or or sometimes just go straight to the bone marrow, especially if they have a substantial tear. I just think sometimes a substantial tear, we're usually asking a little bit too much of platelets, and we typically need a more potent injectate like the bone marrow stem cells.
Dr. Powers, I think you have a unique patient. Actually, we got one question here. I had a PF in my left foot. As it healed, I also got it in my right foot. Is that common?
So we see that all the time. Um, we see bilateral plantar fasciitis a lot. I would guess, without having a number in front of me, maybe around half the people who get plantar fasciitis end up having it on both sides. If not at the same time, then at some point. Um, and I would say maybe half. It just seems to affect one side. We know there's certain mechanics of the feet that make you more likely to have plantar fasciitis. If you have flat feet, you typically do something called hyperpronate, which is where certain aspects of the inside of the foot take on more of the load while you're walking. That can predispose you, but there are other biomechanical factors as well, and I'm sure genetics. And so all of those factors tend to affect both feet. And so a lot of patients will have it on both sides.
Yeah, can I add something there? There's not a lot of data on this, but there is some thought that, since the nerves that go to the bottom of the foot come from the low back, in particular the S1 nerve, one of the lowest nerves in the low back, goes to the bottom of the foot. If there's some irritation of that nerve or maybe some mild compression of that nerve and it's not functioning at full capacity, let's say, the nerves themselves can elaborate or secrete actually inflammatory chemicals through their nerve endings. So there's some thought that over time, if there's some irritation of that nerve, even if you're not feeling nerve pain, that the tissue that nerve goes to can start to break down and become inflamed, degenerated over time. So sometimes we want to think about that and maybe combine it with some platelet injections around the nerves in the low back, if it seems to make sense in that person's situation.
Great answer. I personally had a really bad case of plantar fasciitis, and I'm always a big proponent for this procedure because I battled it for about 6 to 8 months, and this really wasn't something that this is before I was doing what I do, and I would have done this years, light years earlier if I could have. I tried everything that I could have, and I'm super grateful that we offer this to our patients. And the fact of, and Dr. Pops actually has an interesting case where the patient actually had loss of the actual fat pad. And Dr. Pops, I believe you used MFAT for that.
Yeah, so I had a patient of mine who came in with a case of plantar fasciitis. She'd been treated previously by her podiatrist, who did a number of steroid injections on her that would help for very short periods of time. And so after multiple steroid injections, by the time that I saw her, I was able to see on the ultrasound that her fat pad had totally worn away. And so what we did was we basically took a fat graft from her backside and then was able to inject that uh, around into the fat pad where it had worn away, and we were able to actually create a new fat pad for her. And so she previously to doing that had about a year and a half of really severe 8 or 9 out of 10 pain. And when we followed up with her at 3 months, she was 1 or 2 out of 10 pain, and still improving. So worked very well for her. We also treated the plantar fascia at the same time, and she had a great result.
I think using shockwave in this type of a problem is also a really effective treatment. It's just a different strategy. We didn't really focus heavily on that today, but it's just the administration of high energy, invisible ultrasonic wave that creates a little micro trauma in the tissue. Kind of hurts a little bit as you're doing it, but you can get sometimes quicker relief after several sessions, maybe 5 sessions, done maybe 1 to 2 times a week for 5 sessions, you can get something maybe a little quicker of a response than a PRP procedure. So it is an option to discuss during the consultation.
Yeah, I find that shockwave in combination with PRP is often more effective than just the shockwave or the PRP themselves.
And then there are times where if the PRP is not sufficient, maybe somebody gets 50, 60% relief, rather than doing a second round of PRP or platelets, we can move to doing some shockwave to try and augment the results of the first treatment. So we can combine those.
One more question here. If PRP fails, how long to wait before considering having a bone marrow transplant? Answer live.
So I typically follow with patients around 3 months, and if they're not having significant improvement by 3 months, then I would start talking to them about other options. Now, if they've had 50% improvement or something like that, substantial but not quite where they want to be, then oftentimes we'll see maybe check back in at 4 or 5 months and as they're still improving. But if they've only gotten a little bit of improvement or none at all, then that's when we consider other options.
I think this is
at
a
that point.
great, I think it's a great discussion here where it's about expectations and talking to the patient and really following up with them and making sure that you have good follow-ups and seeing where their expectations are. Are they, what's failure, right? And that'd be the first question I ask that person who asked the question. What is failure? So is that no relief whatsoever? We rarely see that. We usually see at least some improvement. If that improvement's less than, they're not able to do any of the activities of daily living that they want to do, that they're being taken away from, that's when I would consider different options. It'd be a bone marrow concentrate procedure, not a transplant. Just want to make sure we rephrase that. We're not transplanting. We are aspirating and concentrating. And then we're going to put that in the injection. That would be, again, if there's interosseous possibility, if the bone is inflamed, that might be a reason to do that as well for bone marrow. There's a lot more evidence on bone marrow for bone lesions. So I don't know if that's answered your question, but good question. All right. Well, listen, thanks for everybody for jumping on. We really appreciate your time. Thanks for jumping on your lunch break. If you or a loved one is suffering from plantar fasciitis, maybe a S1 radiculopathy that Dr. Lieber mentioned, please make sure you get in to see one of our physicians, board certified physicians at one of our locations in Sarasota, Tampa, St. Pete, or Orlando. If you have any further questions, please feel free to reach out, jump on our socials, learn something, and thanks for tuning in.
Okay, take care, everybody. Bye-bye.
Bye.